All right, we are ready to go. If you are watching this live, you're watching on Facebook. However, we will upload the recordings to YouTube as well as Instagram and other social media outlets. Our marketing team will handle that. But good afternoon, good evening, good morning, wherever you may be. Dr. Money here from the Centeno Schultz Clinic, the top five golf guy. And today we are going over the top five golf swing related injuries, knee edition. So without further ado, let's get started. A little bit about me. Again, my name is Dr. Brandon Money. I'm one of the attending physicians here at the Centeno Schultz Clinic. I am board certified in physical medicine and rehab by the American Board of Physical Medicine and Rehabilitation. I'm also fellowship trained in interventional orthopedics, interventional orthobiologics here at the Centeno Schultz Clinic. I'm also certified by the Titleist Performance Institute, and golfers may have heard of that before. If you have not, TPI for short is a network of golf teaching professionals, physical therapists, chiropractors, strength trainers, physicians, and other experts that have additional training in how the golf swing and the body work together. Because let's be honest, everybody's golf swing is different, and you need to be tailored specifically towards your swing and your injuries. And while my wife may use the word obsessed, I prefer enthusiast. I am myself. I'm a golf enthusiast. If you want my personal Instagram, golf.usa, it is right there on the screen. Okay, so knee addition. We're going to talk a little bit about anatomy of the knee first. And so there's four bones that make up the knee and around the knee. We have our femur, which is our thigh bone, our tibia, which is our shin bone, our fibula, which is on the outside of our shin bone, goes all the way down to the ankle. And then we can't not forget about the patella, which is our kneecap. And there are also lots of muscles and tendons that surround the knee that help provide movement of the knee and other structures, as well as stability of the knee. And the tendon tissue is actually the tissue that connects the muscle tissue to the bone, which allows us to be able to move our body. And so the four main ligaments of the knee, there are others, but this isn't a deep medical school anatomy lecture, so we'll just stick with the main four. We have the MCL and the LCL. Those are collateral ligaments. They're located on the inside. By inside, I mean towards the other knee. LCL is on the outside of the knee. The ACL and the PCL, they cross over each other deep inside the knee. And so those are cruciate ligaments, and cruciate means cross in Latin, which is why they're appropriately named cruciate ligaments. And so let's dive right into number one. Everybody's heard about meniscus tears, meniscus injury. And so a little bit of anatomy of the meniscus. You can see in the picture here, there are two C-shaped structures that really wrap around the inside and the outside of the knee. They help provide cushion between the two main bones of the knee, the femur, the thigh bone, the tibia, the shin bone, at the knee joint itself. And so for most people, they will develop degenerative tears as a result of chronic osteoarthritis and joint instability. And what do I mean by instability? Well, we'll get to that in just a moment or two. Okay, so a little bit more about meniscus injuries. Most meniscus injuries, most torn menisci do not cause pain. What do you mean, doctor? There's an injury, there's a tear. It must cause something. Well, a significant portion of the population that's never had any knee pain, they're walking around every day, living life, and they have meniscus tears and they don't even know it. Why? Because they've never had any imaging done, because they've never had any symptoms. And so, as we continue to add candles to our birthday cake, the likelihood of having meniscus tears continues to go up and up. If we look at this MRI scan here, we can actually see a side view of the knee. And so the left side of the picture is the front of the knee, the right side is the back of the knee. We see our green little triangle and our red triangle there. That's the front portion and the back portion of the meniscus, respectively. And we can see circled in red, we can see a white line that's going through that meniscus. That's a tear in the meniscus itself. And this is a patient that doesn't have any meniscus related symptoms. The symptoms they experience are actually on the other side of the knee. And so there's all types of different types of meniscus tears, and they're certainly not all alike. And the meniscus itself, the majority of the tissue of the meniscus does not have very good blood supply or any blood supply at all. And so those tears oftentimes cannot heal on their own. Next, patellar and quad tendon injury. And so the quad tendon actually attaches four muscles, quad means four, to the top of the patella or the kneecap. And the patellar tendon is on the other side, attaches the bottom of the kneecap to the top of the tibia or the shin bone. And either one of these tissues are very often used as graft tissue during reconstruction for ACL tears. And so they're taking pieces of high quality, good tendon in order to replace the torn or damaged ACL. So, unfortunately, as a result, if that's the situation and circumstance, then they're taking viable tissue and there's not as much tissue in that area to be able to do their job. And so, this image on the right here, not a graft site actually, this is a patellar tendon. The whole tendon itself is outlined in red and it's very thickened and chronically tendinopathic. A normal patellar tendon thickness is only about half of what you see here. And the yellow circles are actually defects or tears within the tendon. And so in this specific patient, these tears were not visible by just doing a diagnostic ultrasound evaluation. And so once I began injecting that tendon, we started to see those defects open up and pop up very easily. And so just because we don't necessarily see it on an MRI, on an ultrasound, oftentimes once we inject that, we can start to see those tissues open up. One of the tendons in my body was actually very similar when I had it treated. And so when we looked at it under ultrasound on my body part for my tendon, it looked like it was a little frayed, but no big deal. However, when we started injecting it, we could actually see some of those tears open up. All right, next. So a little classification of tendon tears or tendon damage, because saying the word tear when we're talking about a tendon is like saying the word car. There's all sorts of different kinds. The vast majority of patients I see that have quad tendon or patellar tendon tears, they fit in really the first three categories, either tendinosis, partial tear, or a full thickness tear. Very, very seldomly do I see a complete tear, which essentially means that whole bundle of tendons is completely torn and pulled apart from each other. And so 99 point something percent of the patients that I see fall in those first three categories of tendinosis, which is a chronically irritated tendon. There may be some small tears in the tendon itself. Some of the tendon fibers are torn with a partial tear. Full thickness tear means the tear is extending from the entire top to the bottom of the tendon tissue itself. And then we've already explained the complete tear with retraction. Okay, moving on. Number 3, knee joint osteoarthritis. Very, very common in individuals. And what is osteoarthritis? It's such a complex disease process that is so much more than just the loss of cartilage and really needs to be considered as such. And because of this, it can't be really simply described by a single definition. And so, with respect to instability of a joint, instability often can help accelerate degenerative changes in and around a joint, like osteoarthritis. And so, instability basically means things are moving around more than they should. So, think of the knee like two knuckles that are sitting on a platform and rocks back and forth like this. Obviously, it's more complex than that, but let's talk about it and break it down very simply. So, there are a number of structures that help keep that stable without excess movement so the knee is able to do its job properly. Um, Unfortunately, whenever things get a little bit unstable, that's kind of like a loose lug nut on a wheel of a car. You drive it for a mile or two, no big deal. You wait a couple oil changes to get that addressed. Well, then we're having some other issues that can develop, like accelerated osteoarthritis. So we look at this image here. This is a knee. Our circled area on the left side of the picture is very severe cartilage degeneration. The white itself is actually fluid that we can see. But if we look at that cartilage tissue, we don't see much left on that side compared to the other side of the knee. Okay, moving on. And so, a little bit about knee osteoarthritis in general. So, knee OA affects about 10% of Americans. However, many more actually have osteoarthritis, and it's either not causing symptoms or they don't even know about it because, once again, they've never had any images because they've never had any symptoms. The lifetime risk of developing symptoms associated with knee osteoarthritis, or OA for short, is about 45%. And so the findings we see on an x ray, on an MRI, on a CT scan, those actually represent later stages of joint remodeling. And some of those findings include cartilage degradation of the joint, loss of joint space, osteophytes, aka bone spurs, and then also meniscus degeneration, and a whole host of other things. Okay, number four, ACL tear. Very, very common. I'm sure the vast majority of people that watch this have at least heard about it. Very common in athletes, very common in cutting, pivoting sports, football, soccer, rugby, so on and so forth. So ACL stands for anterior cruciate ligament. It is an integral stabilizing structure of the knee. And what it does, it actually limits the tibia, the shin bone, from shifting forward with respect to the femur. Also helps prevent excessive rotation as well. And so when we do an exam on any given patient that has knee issues, sometimes we can identify laxity of that ACL. And even without a tear, that can ultimately result in a painful knee or faster osteoarthritis progression. And so sometimes we find the laxity in a patient that's never had any imaging. We go ahead and get an MRI of the knee. MRI says, hey, ACL looks good, but we've already identified that's a little bit stretched out. Ligaments are essentially pieces of duct tape that help hold bones together. Now, due to age, injury, trauma, genetics, life in general, we can get a little bit stretched out to where now it's acting like a tight rubber band instead of a piece of duct tape. Sure, it's still holding things together, but there's a little bit of give that over the course of years and decades can accumulate to that more rapid osteoarthritis progression. And so, with respect to ACL tears, reconstructive surgery is often recommended even in patients that have partial tears, for example. So ligaments are kind of like tendons as far as severity and different grading of tears, just like what we saw a few slides ago. And there's approximately 150,000 ACL reconstructive surgeries that are done every year, many on patients that may not absolutely need surgery. And so even after reconstructive surgery, it can result in accelerated osteoarthritis. And 20% of patients that have had a reconstruction progress to moderate to severe osteoarthritis after only 10 years after their surgery. And so there's a 3 times increase in osteoarthritis on a knee that has been reconstructed for an ACL tear compared to the other side that's never had surgery. And so the MRI on this slide here is a side view of the knee. Once again, we've got our kneecap here on the left side in the front of the knee, outlined in red as a very healthy, normal appearing ACL tissue, read by the radiologist as normal, read by me as normal. However, when I did an assessment of this knee, a very comprehensive physical exam, we saw some underlying laxity of the tissue, meaning that ACL is not doing its job of holding things in place like it should. All right, number 5, Baker's cyst. Oftentimes a very incidental finding, meaning we find it on an exam, we find it on imaging, but more often than not, probably doesn't cause symptoms. So Baker's cyst is basically a fluid collection in the back of the knee. And so it occurs due to a valve-like connection between the knee joint capsule, between two muscles that are in the backside of the knee. And so if you've ever blown up a balloon and you get a balloon that has a little extra weak spot or a nub in it, whenever you blow it up, that kind of sticks out. That's really how a Baker's cyst develops. And so if that fluid collection gets large enough, it can actually limit knee flexion range of motion because it is taking up space. And if large enough, it can sometimes create nerve related symptoms because of the nerves that are back there that can get irritated or compressed. All right. And so Baker's cyst itself is usually not the main issue when we're talking about a knee because the body just doesn't send fluid there for no reason. There has to be a reason for it. And that's typically due to excessive swelling related to knee instability, related to knee osteoarthritis. And so oftentimes doctors will drain the fluid. And then maybe after a couple of weeks, couple of months, that fluid comes back. Why? Because you're not addressing that underlying issue of that instability, that change in the joint environment that creates that excessive fluid. And so looking at this image here, this is an axial image of the knee itself. So we have the kneecap there on the top. We can see a piece of that. All of those white little collections are fluid on the front left side, or the top left side on this picture. That's from the knee joint itself. But back here on the back side of the knee, on the bottom of the image, that's actually that Baker cyst that you can see through those two muscles in the backside of the knee. So the fluid just kind of gets stuck there, and the body often doesn't do a very good job of resorbing that fluid that develops. So now that we've identified the top 5 commonly seen knee injuries in golfers, and lots of other people as well, you don't have to be a golfer to appreciate this. What the heck do we do? And so this is kind of the insider information. This is what the experts do. This is what the doctors that know what's going on. This is what I do. This is what all of my doctor friends and what I recommend to my friends and my family and close friends do. And so we go find physical therapists, chiropractors, golf teachers that are TPI experts. They have the expertise, they have the knowledge, they know the correlation between certain injuries and why you swing the way that you do. Now, I always like to recommend starting with the easy stuff. Weight loss, if you're carrying around too much weight, lifestyle modification. And so if you are a diabetic, get your blood sugars under control. If you're a smoker, please stop. If you consume too much alcohol, cut back. All of those things all play an important role into the overall health of the body itself. And so let's say you've done the easy stuff, the things that you can control very well, and you're still not where you want to be. Well, number one, you need an evaluation from an expert. Then possibly considered some type of orthobiologics treatment, such as platelet-rich plasma or PRP, to help promote tissue healing and tissue repair. Number one thing, avoiding high-dose cortisone or steroid injections. High-dose steroid injections have been shown to accelerate arthritis progression, create worse injuries in tendon tissue, and overall, they're just not good for the body. Now, surgery, absolute last resort. Don't get me wrong, my definition of needing surgery is different than a surgeon's definition of needing surgery, and that's okay. That's just because we have different tools available to us. And the reason why I say working with a TPI expert is important, because that's what the pros do. Nearly all of the top 50 golfers in the world, they choose TPI experts to work with, whether that's strength and conditioning specialists, physical therapists, chiropractors, golf teachers, because these are the people that know how to relate your golf swing with your body. And let's be honest, your golf swing is different. Your body's different from everyone else. Okay, so let's talk a little bit about PRP. Maybe the first time you've heard of it. If you're watching on our Facebook or YouTube page, you've probably heard it before. But what is PRP? So PRP is a preparation of concentrated platelets that comes derived from your bloodstream. So those healing factors are isolated and concentrated to a much higher concentration than what you normally have circulating around. And those growth factors or healing factors, they help boost tissue repair and healing. What I tell patients all the time is all we're trying to do is help get the body to help heal itself. There's no magic fairy dust out there that's going to turn you back into a 17-year-old again. I wish I'd be first in line if that was the case. And PRP can help treat musculoskeletal conditions. So tendon injuries, ligament laxity, ligament tears, injuries to bones themselves, as well as joint structures, typically can be benefited by a treatment of PRP when it's indicated. Okay, so be careful. These are a couple caveats that you need to be mindful of and be aware of. Not all PRP is the same. PRP is like saying the word car, a million different kinds. So the dosage is key. And so if somebody doesn't know the dosage that they're offering PRP to you, run away. There are too many clinics out there that have inadequate training, inadequate safety protocols that are doing this stuff. It's popping up on every corner because the machines are easy to get to create low quality PRP, and who knows what the heck is in that. Now, You don't want somebody doing blind injections without image guidance. And by blind, I don't mean they're closing their eyes and they're just sticking a needle in. However, they might as well be, because personally, my vision only goes to the skin surface. And if we're targeting important structures underneath the skin, we need to know exactly where we are. Number one, so we can target those specific structures. But number two, so we can stay away from the things that we don't want to hit, like nerves, like arteries, like veins, so on and so forth. And you've got to do your homework. Are you going to see the doctor in this clinic, or are you going to see their nurse practitioner or their physician assistant? Don't get me wrong. NPs and PAs are great providers. My wife is a PA. But non-physician providers, they don't have the training, education, or expertise necessary for the diagnosis and management of these often complex conditions. And the best in the world at doing this, they have specialized orthobiologics training. They're certified by the Interventional Orthobiologics Foundation. Those are the people that you want to target. Those are the people that you want to see. And if you have to hop on a plane to see one, do it. Trust me, it's worth it. Okay, so these are some questions to ask. So you found somebody that does PRP or does orthobiologics. So what can you ask them to be more educated so you can make the best decision that is in your best interest as a patient? How is the PRP prepared? Is it an automated machine that looks like a printer that sits on the top of a desk, or do they have a full blown out lab like we do about 20 feet that way from my office? What's the concentration of the PRP? Do they even know? Do they test? Most don't. Probably 99+% of clinics that say they do PRP have no idea. What type of image guidance is being used for the injection? Are they using ultrasound? Are they using x-ray? Likely, hopefully, they're using a combination of both, depending on the structures that are being injected. What exact structures are being treated, and why are we treating those structures? Because if somebody just says, oh, we're going to do one injection into the joint, and you have all these other things going on, well, number one, have they even diagnosed those things? And number two, how do you expect to get improvement if they're not treating all of the pertinent structures? What other options are available to you? Corticosteroid injections, physical therapy, exercise, diet, lifestyle changes, maybe bone marrow concentrate or adipose or prolotherapy, or surgery could be an option as well. What other options do you have as a patient? Because my main job is providing you with education and the information available so that you can ultimately make the best decision that's in your best interest. And whether that's being treated by me, whether that's doing something else, I fully respect and appreciate that. Last thing to ask, at least for now, did the physician undergo specialized orthobiologics training, perhaps a fellowship in this? Because it's not something you can just learn by a week-long course. This takes years and years of experience to become an expert, and you owe it to yourself to go to those individuals so you can ultimately have the best opportunity to get back to the lifestyle that you're accustomed to and that you want. All right, a little bit about our clinic, the Centeno Schultz Clinic. We're based out of here, Brookfield, Colorado, one of the Denver beautiful suburbs. We are the world leaders in orthobiologics treatment for musculoskeletal conditions. We have invented many of the procedures that are now used across the world. We do constant research. We constantly evolve. The list on the right, I know it's kind of blurry, but that is a non-exhaustive list of the research papers that we have had published in scientific journals, because research is key. If something changes tomorrow, that there's a new way of doing something, guess what? I want to know about it because I want to learn how to do that. And what we do is we maximize the body's own ability to heal by utilizing a number of orthobiologic-based treatments, including, but not limited to, blood platelet-rich plasma, bone marrow concentrate, which contains MSCs, mesenchymal stem cells, or mesenchymal stromal cells, medicinal signaling cells, lots of different names associated with that. Also prolotherapy, which is typically hypertonic dextrose that can help stimulate the body to heal on its own. And over the years, we've published multiple studies utilizing orthobiologics specifically for the knees, osteoarthritis, bone marrow lesions, ACL tears, etc., so on and so forth. All right, final thoughts. The golf swing itself. I know we didn't get into the golf swing, but I'm not a golf teacher. Please don't ask me for swing tips. I will certainly give you the wrong ones. It's complex. It's individualized. Your body is also individual. You need a specialized evaluation and plan that is directed towards you. There's no cookbook for this that says, oh, this is page 27. This is the knee page. This is the back page. This is the shoulder page. This is what we do. It doesn't work like that. You are a human. You are not a robot. We are all different. And what we need to do is we need to start conservative, and then we advance up the ladder as necessary. You don't jump into having heart surgery if your cholesterol has just been shown to be a little bit elevated. There's lots and lots of things to do prior to then. Same thing when we're talking about knees and shoulders and hips and spines and everything else in our body from a musculoskeletal perspective. And so we start conservative, the easy stuff, like I referred to, and then we work our way up if we're not getting where we want to be. And it's all about progress in a forward direction, not perfection. If you'd like to learn more about what we do here, about our research that we've published, you can always visit the Centeno Schultz website or the Regenexx website. All of that is listed there. Final slide here, just some references that we utilize. But that's it today. Top 5 golf swing knee injuries, not specifically from playing golf itself, but often what individuals that are golfers or non-golfers experience. And so even somebody as good as Tiger Woods has had a million different surgeries to his body. He's had ACL tears. He's had lumbar disc issues. He has knee osteoarthritis. I'm certain of that. And that's not even including everything from his car accident trauma just a few years ago with his ankle and leg. But that's all for today. I will see you in a few weeks where we'll be going over another topic, another top 5. What's it going to be? I guess you'll have to tune in to find out. Thank you, everybody. Take care. Have a wonderful day. Hit them long, hit them straight. Enjoy the summer.